Good morning, everybody, and welcome to MacroPro and Friends webinar edition of 12 Days of Christmas, or 12 CEUs of Christmas. We're glad that you can join us today. I am with Leslie Dilbeck, my friend. Leslie, how are you?
I'm doing awesome today. It's sunny here in San Diego, so I feel very fortunate for that.
It's a little bit drizzly here up in the Pacific Northwest, but it's nice, crisp, and it's ready for Christmas weather. Are you doing things special for Christmas?
I am. I'm headed to Puerto Vallarta a week from today. So my adult kids and my husband and I will have a hotel Christmas, and we just haven't taken family vacation in a while. So we're excited to be together and just make some good memories together. So I'm excited.
That is exciting. You know what? I've never asked this before in a poll question, but if you're going away for Christmas and you're not going to be home, could you just put that into the chat box to let me? It'd be interesting to see how many of our viewers are actually going to be away for Christmas. You know, not a lot of people do that. I think most people stay at home and they're with family, but I think there's something really fun about traveling during the holidays.
Yeah, I bought a little Christmas tree for my hotel room, and each of us are bringing one small gift that we can fit in our luggage to give each other and exchange gifts, and it should be fun. We've never done this before. It's kind of weird because I have no presents under my tree right now, but I also have a new puppy, so that would be a disaster. I'm excited that we'll share our gift giving over there, and we'll see what happens, but I'm curious to see where other people are going.
Right. So, well, I'll look at that while you're speaking and maybe mention that at the end. So,
Awesome.
Leslie, you want to tell everybody about this new podcast that you and I have?
Yeah, thank you so much. So Diane and I started a podcast about a month and a half ago. It's called White Knuckling It Through Life. And it's about, the struggles we face as humans. We all have different struggles, different challenges. And our hope is that it will encourage people to know when they're in the midst of their struggle that there is hope, there's light at the end of the tunnel, and we'll be having different guests come on and share their stories and talk about where they're at now. The last episode was my daughter sharing about her struggle with mental health, and we have some people also coming on sharing about addiction, their child's addiction, and where they're at today and how they turn that into something that can bless other people. So tune in. It's on Spotify. We're trying to get it up on other platforms, but my 20-year-old son, who's kind of the one behind doing all of that, is in finals week at college this week, so he'll have some more free time to put those up on Apple and Stitcher and that. But for now, look for it on Spotify, White Knuckling It Through Life.
Excellent. Well, thank you very much. Now, Leslie's going to be talking about ratings, and one thing we need when we're doing ratings is records. So if you need records, just remember that MacroPro can get those for you. Now I'm going to do a little bit of housekeeping before Leslie gets started. So this webinar is worth 1 CEU for California. You must be logged on to the platform through GoToWebinar. So if you're calling in, you will not be getting a CEU certificate. However, for those of you who are logged on, you will receive that within 1 hour of this presentation. We do have handout materials, so be sure to download those on the control console so you have that. Leslie is happy to answer any questions, so please put that in the chat box, and I will ask her those questions at the end of the presentation. And then lastly, if you would like to see this program again or any other program, you could go to the MacroPro YouTube channel. As for now, Leslie, take it away.
Thank you. Thank you so much. Well, today we are going to be talking about COVID-related impairment. I will tell you, last year I actually spent the holiday season putting this presentation together, and we still know that a lot has changed. So just so you're aware, before I do this presentation, I always look to see if there's anything new that I need to bring to my audience about long COVID related impairment. And I actually have something new that was kind of cool that I found on the NIH website. Just so you know a little bit of my background, I'm Vice President of iRatings. I started in claims as a trainee, didn't know anything about workers' comp, but the salary was pretty good to pay off my hefty student loans. So I did that for about 5 years, both on the California state side and on Longshore. After that, I went to Sharp Healthcare and worked with over 200 physicians specializing in everything from allergy to urology. And I had a team of people helping them write the reports. When SB 899 was implemented, I was tasked with training the doctors on the AMA guides. I've been an AMA guides expert for about 17 years now. I'm a certified expert in disability and impairment rating with iRatings. The team that makes up our group is really coming from a claims background, looking at multiple jurisdictions. We all are certified by IAIME. So that is a certification that is given to doctors. So we had to take a test that doctors take to demonstrate our comprehension and acumen on the AMA guides. We're experts on all editions, and we work both in California, Nevada, Texas, Longshore. Wherever the AMA guides are used, we are asked to take a look and validate the impairment rating. And we also have trial and testimony experience. Before I dive in, I think it's important for you to understand how we're coming up with this training session and what knowledge we have and what we would do if we were looking at a case that is long COVID related. We've had a good handful of cases coming through now that these people have reached maximum medical improvement. So just for your understanding, we're really looking at the evidence contained in the doctor's report to see if the impairment rating is supported. And if it's not, then we tell you what the guides say and what the evidence is pointing to as far as what the impairment rating is. We will provide a detailed discussion on what the doctor did right and what the doctor needs to clarify or correct in his or her assignment of impairment. And providing you that will give you some good food for thought, whether you're going to talk to the doctor via letter, correspondence, deposition, or perhaps you may be making other choices on your file. Maybe you're trying to just try and negotiate based on the quality of the doctor's report and maybe point out the errors to the opposing party to reach your settlement agreement. So, you know, we take these impairment values and assign them based on what the evidence tells us, but we'll also take a look at what if you did nothing to the rating at all, the impairment rating, and we stranded out through our schedule, California Permanent Disability Rating Schedule, to get to the final PD value of the case. So that's a little bit about what we do. Hopefully that gives you a good idea, a good foundation of what iRatings is about and how we go about looking at certain cases. But let's go dive right into our actual topic for today and our goals for today's training session, which I think will be helpful for you as you start to get these cases that come through your office and across your desk. So the goals for today, first of all, is for us to revisit the basic concepts of the AMA guides. Because we're dealing with such a strange and extraordinary, I will say, condition, it's important for us to really look at some key components that get overlooked and maybe a cause for challenge on some of the impairment ratings assigned. We're also then going to talk about potential long COVID related impairment, and I'll give you some case examples on cases we've received. Now, what I stated at the beginning is a lot has changed even since I put this presentation together a year ago, but I give you a little inside scoop on myself. I really put aside putting this presentation. My colleagues at iRatings were telling me, you need to put something together, people want it, and I was so sick of hearing about this topic. I felt like every webinar I went to, every conference I went to, this is what was talked about. Anytime I turned on the TV, the radio, was in Starbucks, this is like the word COVID, and I was so sick of it. And it was one of those things that it was on me to, you know, get past that and actually dive in and really look at this information. But I do remember back in August of 2020, so March of 2020 is embedded in my mind because that's when kind of the world turned into Dr. Seuss world, right? Everything was up, everything that was down was up, and everything up was down, and it was just kind of crazy. In August of 2020, so a few months later, I was asked by some actuaries for one of our large insurance clients to just provide them with some information on what they could expect with respect to COVID-related impairment. That was only 3 to 4 months after, 5 months after we really, were seeing this shutdown of the world. And I left them very unsatisfied because, as you know, if you were even anywhere remotely part of our universe or our planet during that time, everything was changing on a daily basis. And so I told them basically death is the worst case scenario and getting completely 100% resolved is the best case scenario, and who knows what will happen in between. We knew the lungs were going to be a challenge just based on what we were seeing at the emergency rooms. And what we were seeing with respect to the respiratory impact of the condition, but we didn't know what else would come about. So I'll get deeper into that in a minute, but I really want to focus first on some key concepts that we, can look at and go, yeah, of course I know that. I've been doing claims for 20 years, maximum medical improvement, but let's really talk about it as it pertains to this diagnosis. This has been the challenge with long COVID, is really figuring out when these people reach maximum medical improvement. So we have to look at what the guides tell us. And the guides tell us that we have this condition of stabilization. It refers to a date from which further recovery or deterioration is not anticipated, although over time there may be some small change. And then we look at another iteration of it within the guides themselves, 5th edition, telling the doctor, an impairment should not be considered permanent until the clinical findings indicate the medical condition is static and well stabilized. So a good example, we'll go simple for us on this complicated topic, a shoulder surgery. You have a claimant who has a shoulder surgery. They wouldn't be appropriately considered to be at maximum medical improvement until they've completed their course of physical therapy post-op. That's just something that, if you've been doing claims for long enough, you kind of know that's going to be anticipated. That's why you would authorize it, perhaps. And you know that type of treatment is going to get that person to a better level of functionality. So what we're seeing with long COVID is it can take some time, because these individuals have these protracted symptoms post SARS-CoV-2 that lasts for months and months and months, and you kind of see them get a little bit better, and they report different things each time they come in. So just keep in mind, it doesn't have to be an exact, one static line. It's going to be a little bit curvy, right? There's going to be some good days and bad days, but for the most part, if you were to put those good days and bad days on a line, you would kind of see a nice kind of static. What I mean by static, that you would see the ebbs and flows on a constant basis that don't change too much over time. So keep that in mind. You don't want somebody prematurely determined to be at MMI, because your impact on your permanent disability dollars could be higher than if you were to let them get their full course of treatment. But we are seeing all sorts of different things come through as far as cases we review. So it will be a case-by-case scenario, and I'm sure that's what you love to hear, right? I think in claims we kind of would like everything wrapped nice and neat in a package, but this is one of those conditions that doesn't lend itself to that. Now, the next concept under the AMA guides that can be kind of a rat's nest is the difference between impairment and disability. They kind of sound like the same thing. They kind of do go hand in hand in our system, at least. But let's talk about the difference between the two, and as it's defined by the guides, to hopefully help you understand some of the challenges with this diagnosis and how you would actually rate it out. So impairment, I want you to think of medical determination. It's a significant deviation, loss of use of any body structure or body function in an individual with a health condition, disorder, or disease. Whereas disability is activity limitations or inability to do certain things, or participation restrictions in an individual who has a health condition, disorder, or disease. So one's a medical determination, the other is more subjective in nature and dependent upon the person's abilities to accomplish certain tasks based on their condition. So when we think of that, we have to look at impairment first telling us that there needs to be something objective to base the condition on, the rateable condition on. It's the person's failure to return to normal. So again, a good, simple, easy example would be if I somehow amputated my index finger off and they weren't able to reattach it and it was completely gone, I'd no longer be 100% whole person. So just keep in mind that's the thought behind impairment. There's the subjective basis where disability is the gap between what someone can do versus what they need to do. And this becomes a challenge in our system because people you know, maybe deconditioned, maybe they weren't very good at the beginning before they got their diagnosis. Maybe their motivation's off. Maybe they have some other stuff going on at home that's impacting their motivation to go back to work. So we see these challenges persist in our system regardless of diagnosis. We see it in low back cases, we see it in shoulder cases. It's always astonishing to me when I see, you know, players, pro athletes. I'm a big football fan, so you know, like a pro football player who's not going to be retiring soon, somehow get through a full-on rotator cuff surgery and be back on the field within a year's time. So the motivation factor is deep there, right? And challenge. They're doing a job they love. Versus the let's say the longshoreman who maybe doesn't care for their job so much and you know may have a difficult time getting back to work. So those two ideas are very challenging for you. I want you to just keep them in your pocket as you look at these types of cases and really dig deep into those medical reports and look at what the medical report is telling you objectively, and then build from there, because I do think there is some leeway when we have to take into consideration the person's subjective complaints, which are more part of that disability bucket than the impairment bucket. Some other key concepts that I want to draw your attention to, page 19 of the 5th edition. This is super important with this complex diagnosis because you're seeing all sorts of different kinds of symptoms come up and potential rateable conditions. So where do you begin? Let's just keep it simple. I once had the best boss when I worked at Sharp. He was a JD, MD, MBA. He was probably one of the smartest guys I knew, but he was very good at training and mentoring me. And he always said, keep it simple, silly. So I try and look at things from that perspective, and I think it's important to keep it simple and build from there, and that's how we do the work we do at iRatings. So if you've got something where there's multiple conditions involved, let's start first with what the guides tell us on page 19, the organ system where the problems originated and where the dysfunction is the greatest, and use that as the basis for evaluating impairment. And then we'll build from there, alleviating or getting rid of any kind of overlap, and then reaching our conclusions on whole person impairment. Now, the next area I want to call your attention to is page 10 of the AMA guides. And this is very, very challenging for long COVID disorder. This is going to be problematic in these cases, but let's look what they tell us. Subjective concerns, including fatigue, difficulty concentrating, and pain when not accompanied by demonstrable clinical signs or other independent measurable abnormalities are generally not given separate impairment ratings. So I am not a fighter in the claims world. In fact, that's maybe why I'm not a claims person anymore. I'm more of a lever, and I try and look at things from an objective point of view, but I also like to look at things from a practical point of view. So these long COVID cases, you're going to find fatigue, you're going to find people with brain fog, difficulty in concentrating, and you may find them with having joint pain, and there may not be something that's absolutely able to rate out for impairment if you're just looking at it from a very pure form. But we can look at things a little bit outside the box sometimes, and I think that's perfectly normal. So I do want to challenge you on that if you're just trying to interpret the guides very strictly, and I think there is definitely a time and place for that. But when we're dealing with a complex disorder like this, we have to kind of look at what makes sense and what seems appropriate, and we've certainly had to do that on a couple of the cases we've reviewed. So let's talk about rating for long COVID impairment. Now, we first have to figure out what is long COVID, and I'm going to tell you right now, all my citations are taken either from World Health Organization, NIH, National Institutes on Health, or the CDC and a couple of medical journals. I did not go to MSNBC, CNN, Fox News, Twitter, TikTok, or any of those. Okay, so I know that this is a very hotbed of political conversation, which I don't take that approach. So, you know, whether you like NIH or CDC or any of these other organizations, we have to look at, they're the ones telling us how we need to manage these issues. So that's where I'm taking it from. So just so you're aware that this is where my information is coming from, and I do give my source citations for you to go and look at it on your own. It's important for us to define long COVID. Most people with COVID get better. That's beautiful, right? Most people within weeks of the illness get better. And that goes back to me telling the actuaries, most everybody's probably going to get better. There will be some people that unfortunately, you know, die as a result of the SARS-CoV-2. There may be some people in the middle that might have the long COVID related problems. So the CDC tells us that most people get better, but some people do experience post-COVID conditions. There's a study out of Ireland that I do not have in here, but you can look it up, that basically gives, you know, kind of what they're seeing right now as far as long COVID. I want to say it was like 30% of people, you know, may report symptoms of long COVID. And some may be minor, some may be major. They tell us at the CDC on their website, post-COVID conditions are a wide range of new, returning, or ongoing health problems that people can experience 4 or more weeks after first being infected. I have a friend that had anosmia, which is her basically smell issues. Everything smelled like rotting trash, and it still does to this day. And she had COVID in December of 2020. So it can be weeks to months to years. They go on to tell us that that there's other terms we can know this by: long hauler, post-acute COVID-19, long-term effects of COVID, or chronic COVID. They recognize we're still trying to learn who's getting this, why they're getting it, what is it. So be patient with this this horrible virus that, you know, has infected our society, while the experts in the field, the scientists, are still learning more about it day by day. The World Health Organization defines long COVID. They call it post-COVID-19. It tells us that people with history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months or more and can't be explained by any alternative diagnosis. So what are these symptoms? My goodness, look at this, right? Crazy, lots of different symptoms, from tiredness or fatigue to cough to heart issues to fever. Now, I found the coolest thing that I want to share with you guys, and I tested this earlier, so I'm praying it will pop up for me nicely. I'm bringing it up, and if it's not showing up, Diane, tell me. This is on the NIH's website. You can actually go on and look at the body and click at what potential long-term effects of COVID may be present. So muscles and bones, muscle aches, joint pain, reduced mobility. Of course, we have the kidneys. They may have some kidney issues. So this is a kind of a cool little, I don't know, interactive thing that NIH put out for people to kind of see what makes sense. So if you're just trying to wrap your head around it, go here. This is much better than the slide I'm giving you. So just be aware that that's an opportunity for you to kind of check things out. Like, can you get this from that? And that's always been my thing with impairment. Can you get this from that? So you're having to suss it out and figure it out. So let's talk about this. First of all, what I'm showing you here are symptoms. Do symptoms necessarily mean impairment? No. So we have to be aware of that. Just because they're symptoms doesn't necessarily mean they equate to an actual impairment rating. So as we go through the potential impairment, we have to kind of first look what the symptoms are, right? Because that's the whole diagnostic process, is look at what the symptoms are, see what they point to, look to see if there's impairment. Now, the CDC went in and told us some interesting things in 2019. This was very, you know, kind of not the 2019, in 2020. Some of the potential things as far as the COVID-19. Some people who have severe illness with COVID-19 as a result of long COVID may have multi-organ effects or autoimmune conditions over a longer time, with symptoms lasting for a long time. I'm paraphrasing this. Multi-organ effects can affect many, if not all, body systems, including the heart, lungs, kidney, skin, brain. Let's talk about this next line. Autoimmune conditions happen when your immune system attacks healthy cells in your body by mistake. So guess what, guys? When our body was trying to, fight the SARS-CoV-2, it did some boo-boos. It kind of misfired a bit and attacked some of the healthy parts of us, which then caused these other problems. So it was interesting to me to hear, and read that, recognizing our autoimmune system, our immune system is very, very robust, and it can sometimes do damage to us and create more difficulty related to more autoimmune type conditions. So that's another thing I want to point out, is that some of these long COVID conditions kind of look and smell and sound like these autoimmune conditions that we've heard about over the years, like lupus, those types of conditions. So, just be aware that that's kind of some of the things that it might point to if you're trying to kind of touch on experience of how to handle this. Maybe think about certain cases that you've run across that may point to that, where they may be partially work-related. I don't know how lupus would be work-related, but maybe you have somebody with that type of condition and it was, aggravated or exacerbated by employment. So let's talk about long COVID impairment, recognizing what I gave you earlier was symptoms. Now we're talking about potential damage that can be done that then would make you no longer 100% whole. So lung damage is, of course, on the forefront. Heart damage, including inflammation of the heart muscle. Kidney damage, neurological damage, circulatory system damage resulting in poor blood flow, mental and emotional illness. That has actually been quite profound in a lot of the cases I've looked at. Headache, loss of smell or taste, and the list can be altered, because believe it or not, I actually had a case that came in where the guy ended up having brachial plexus because of how he was positioned in a static position while on the ventilator. So these are, part of what you may see, but don't get locked into it. Be ready to be flexible, which is what I hope most of us learned over the last 2 years, is flexibility, right? So we're having to be flexible in how we manage these cases. Now, I'm starting with lung. I'm not going chapter by chapter in numerical order. I'm going by kind of what we've seen. And one of the of course, prominent areas is the lung or the pulmonary system. The first indicator, symptom we see is this dyspnea, which is the difficulty in breathing. Now, if you go to chapter 5, the pulmonary chapter, page 89, they tell us this is a common symptom noted on exam with any type of pulmonary impairment. But first, the doctor needs to figure it out and diagnostically assess it to determine that it's truly related to the pulmonary system. It may be cardiac, there may be a hematologic problem, there might be a metabolic problem, neurological disease, it might even just be anxiety, or it could be the person's completely deconditioned. So the doctor has to sort all of that out, and this becomes where the base for where you're going to go next, what chapter you're going to go to, what the diagnostics are telling you as far as what level of impairment the person has within a certain chapter of the AMA guides. Now, I noticed we have some county and city people on here. You might already know how to do these types of cases. If you're not handling peace officers, this might be completely foreign to you. So I'm going back to KISS. Keep it simple, silly. What I'm going to show you in the next few minutes is hopefully going to alleviate some of your anxiety on how to manage these types of cases. You are not expected to or required to interpret test results. You're supposed to look at the doctor's report and see what the doctor's telling you the test results say. We do at iRatings know a little bit more than the average bear when it comes to this. So sometimes we dig a little bit deeper if the testing doesn't seem to make sense to us. So the diagnostic testing we would see for pulmonary is this spirometry test that measures the person's forced vital capacity and forced expiratory volume in the first second of pushing out breath. So this is a very simple test. If you've ever been tested to see if you have asthma, or maybe you were, doing some type of test for pre-employment, you blow into the spirometer and you just blow, 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 keep blowing. They'll tell you keep blowing, keep blowing, keep blowing. And you do that, and as you're doing that, it's capturing the information that they need to figure out what your pulmonary function is. So that the whole amount of time you're blowing breath out to that first second of burst of air, what that looks like. And then they take a ratio of the two to reach a conclusion on your pulmonary function. The next test is the DLCO testing, which demonstrates diffusing capacity for carbon monoxide. They do a test for that, your VO2 max, maximum oxygen consumption, and then your METs, your metabolic equivalent, or body's ability to use oxygen, typically while doing some sort of exercise. So now we look at, all right, doctor, I see all these equations, which, can be kind of scary when you're first looking at these types of reports. You're going, oh my gosh, I feel like I'm looking at my algebra book again. But really, you just need to go to the doctor's reporting and see what they're telling you if you're going to be rating for pulmonary function and exercise test results. So referencing table 5-12, we are looking at that FVC, FEV1, and that ratio. We're also looking at DCO, or the VO2 max. So as we're looking at that, one of the things I want you to be aware of, a class 1 impairment is 0. If any of these findings are found within the doctor's report, this is basically what would be considered normal. Now, class 2, you do not have to have all of those items to be within these ranges. It can be any one of those hitting the mark, automatically sets that person up for a class 2. It's very important to be aware within these internal chapters, there's these ranges of impairment that are very spread apart. It's not like our lumbar spine DRE categories where it's a 3% bump. These bumps are going to be about 15 to 25% of a bump, depending on if you're at the bottom of the range or the top of the range. So it's very, very important to be aware of that, because don't you think if you rate out a 10% pulmonary or respiratory disorder versus a 25% whole person, that the permanent disability dollars are going to be quite substantially different. So I caution you, if you see the doctor giving automatically top of the range with very little justification, it's warranted for you to challenge that. What takes the person to the top of the range? It could be the top of the range within their own test results that didn't necessarily get them to the next class, but were right on the cusp of it. Or it could be a significant impact on activities of daily living. It could be based on, a combination of all the testing being within certain ranges that, when you pile them on top of each other, seems like it's reasonable to take that person within the top of the range. So it's very important to keep yourself focused on those ranges. And going back to keep it simple, if I could give you like a takeaway on that, is when look at the doctor's testing, compare it to the table, and look to see where the person falls within the top or the bottom of the range based on activities of daily living and the severity or the percentage of their loss of function in their pulmonary ability. Okay, Now we see this happen. This has happened where we're seeing some overlapping ratings where the doctors are stacking them. So for instance, one that just came in a while back that totally contradicts itself. One that came in maybe, let's say, a few weeks ago, was the doctor gave it for pulmonary, but then also gave an asthma score and a rating for that. That would be duplicative, so you can't have both. So the other type of ratings we have seen on these types of cases is asthma. And these cases are rated out through a scoring process, but we're also looking at that FEV1, that first second of blowing out in your spirometry testing. And we're also looking to see how the person's dealing with their ability to do this after use of a bronchodilator, so after use of medication, and also what their need for medication is. So you score this person based on that post bronchodilator FEV1, percent of FEV1 change, or their reversibility. And this is all should all be contained within the doctor's report. If not, you're going to have to write the doctor letter and ask for that detailed information. And then the person's response to medications. And then that last category is the minimum medication that they have to use. You score them up, you give them different scores based on each one of those, up to 4, 0 to 4. And then you add those up together, depending on what their total asthma score is, you assign them impairment. Now, as you see, their ranges of impairment are, again, quite expansive. So word of caution again, make sure you're really looking at that top range being supported based on severity of the scoring or impact on activities of daily living. Now, your takeaway on this one, you cannot do both asthma and pulmonary disorder or respiratory disorder rating. Now let's go to the potential ratings for heart damage, the cardiovascular chapter, chapter 3. You've probably heard, on the news or read myocarditis. You hear myocarditis more often. We hear pericarditis and tachycardia. So let's break it down for you and talk about a little bit about this. Myocarditis is an inflammation of the heart muscle itself and can be rated for cardiomyopathy per table 3-9, page 47 of the AMA guides. Pericarditis is rated per table 3-10. Pericarditis is inflammation around the heart muscles. So again, back to that, the immune system attacking, trying to attack the SARS-CoV-2. It might have accidentally attacked your heart too while you were trying to fight that condition. So we see that pericarditis, and then we see the murmurs or the racing heart rate. Table 3-11. I'm not going to go into each one of those tables because I have an awesome tool for you to go to, which is table 3-12. Of the AMA guides, and it tells you, really, how to go about looking at each one of these. It's very small for you to see here, so you're going to have to go back after today's training and look at it with on your desk at the actual book. But it will tell you to look at the disorder. So, for example, with arrhythmias, it will tell you, the history. The first column will give you the history, and I hope you can see my mouse. It will tell you. You know what? I think I can do. No, let's see if I can do this. Yes, the spotlight tool. All right, I'm bringing it home. Let me just toggle back here. All right, so this first column here is going to show you what kind of history you'd be looking for. So like with the arrhythmias or the pericardial heart disease or cardiomyopathies, you're going to look for that shortness of breath for cardiomyopathy, pulmonary problems perhaps, or organ congestion. What kind of examination record you'd want to see for these various ones. I'm focusing down here on these last 4 because these are the 4 you're going to probably see. Well, the last 3, I should say. You're going to be seeing these last 3: the cardiomyopathy, pericardial heart disease, and arrhythmias. Then assessment of function. What kind of testing needs to be done to reach your conclusions when you're referencing the table for each one of these rateable conditions? And then what kind of potential end organ damage? So this is important for you as a claims person to be on the lookout that, if somebody has a problem with any one of these things, these are the potential other systems and organs that can be affected as a result of that other problem. So it's important to at least have it on your radar, right? Because you got to do your reserving. You're wanting to kind of figure out where you're headed on the file. Not to say that every time a person has a cardiomyopathy, they're going to have lung and kidney problems, but that is a potential for you to be aware of. And then what different diagnoses can be associated with these different disorders. And then they give you the tables that you reference for assigning impairment. So again, you don't need to know you don't need to know how to interpret those test results. All you need to know is, did the doctor put it in their report? So you can go about looking at those tables in a way that is meaningful to you to figure out what you owe as far as impairment, which then equates to permanent disability in our system. Now, this was a really cool diagram. You do have the handout, by the way, that you should be able to download as a PDF. It has this for your reference. This is taken from the National Review of Cardiology 2021. I list the different authors there. This was just helpful to me as from a visual standpoint, just to kind of help me, understand cardiovascular disease and different things that could come about with relation, and that this was created just for the long COVID or post-acute COVID is what they're calling it in this article. So different types of potential cardiovascular problems. You have stroke, the arrhythmia that we already touched on, myocardial infarction, and then you've got the DVT, deep vein thrombosis, potential pulmonary embolism, left or right ventricular systolic dysfunction, or you would know it as left ventricular hypertrophy is really what's ratable in our system, or pericarditis. Don't get too freaked out by this because it can be daunting and scary, but the cardiovascular system we were just now talking about heart and aorta, now we're talking about the whole of the system, which we see these peripheral vascular diseases or aortic diseases. Again, the best reference tool for you for cardiovascular impairment is to just go straight up to table 4-7 in chapter 4, the cardiovascular chapter, to look at the different types of conditions that might be ratable, the disorders that might fall into place. I see these circulation issues crop up every once in a while in cases we review. The person needs that comprehensive exam, of course, but you're wanting to look at pulmonary angiography, CT, or imaging studies. Potential organ damage can be impacted, the aorta, the heart, the pulmonary system. And they go through and tell us, kind of what we need to be looking out for as we go and reference, and what table to go to in this last column here. So you're probably going to see the pulmonary circulation issues, peripheral vascular disease, quite possibly, and aortic disease. That's that hypertrophy I was talking about. These are not super common, but it's worth mentioning because you want to be prepared on what to do if you get these types of cases. Next, we're going to look at the kidney. Believe it or not, I'm going to be able to get to the end in 16 minutes. I bring this up, kidney disease, because it is a potential with some of the end organ damage that might result from some of the issues that are those heart and aorta issues. This is rated per table 7-1, upper urinary tract disease. This is our chapter 7 that we would reference, and it's based on the person's labs, as well as their ability, and their symptoms with signs and symptoms with respect to urinary tract dysfunction. A class 1 just has to have one. All of these classes just has to have one of these things within each column, not and. So just be aware of that. If the person ticks any one of the things within the class box, then they're eligible for an impairment. Again, we have these ranges of impairment. that are about a 15-point spread. So you want to make sure that you're referencing it in a way that is supported based on the objective evidence and impact on ADLs. Class, I would suspect most people would be within a class 1. Most people, a class 2 is somebody with a pretty significant problem to the point that it's somebody that's had a renal transplant. So just be aware of that, if the doctor's going to a class 2 and up, that's a red flag. Other rateable conditions to consider, as we all know, taste and smell. We saw that particularly with the beginning, the COVID at the forefront of the infection. As it mutated, we started to see this less and less, but it's important to be aware these are actually rateable, believe it or not. So let's talk about it. Section 11.4, which is olfaction and taste, page 262. They tell us that a value of 1 to 5% of the whole person is suggested in use in cases involving partial or complete bilateral loss of either sense. Partial or bilateral loss of either sense. And so it can't be stacked. Just to give you a heads up on that, it can't be stacked. So the max would be 5%. Section 13.4, which is the central and peripheral nervous system chapter, page 327. This is important. The maximum impairment for anosmia is 3%. So per the guides, total loss of smell would warrant a rating of 3% whole person. So that's a good baseline to give us. So total loss, 3%. Partial loss, not 3%. Agreed? I think we can all agree on the logic on that. Headache. We've noticed some of these cases resulting in persistent headache. And typically headache wouldn't get impairment unless somebody had some kind of post-traumatic headache, like they got bonked on the head and it resulted, in long-term headache pain. The guides do allow for that in chapter 18. I think it's reasonable considering the vast scientific reporting and medical journals that have told us that these people will have persistent headache. That is probably reasonable to go ahead and do, treat this the same as post-traumatic headache, allowing up to a 3% whole person for pain. As I mentioned earlier, we see a lot of mental and behavioral things crop up. It is challenging. I see people that didn't even have long COVID experiencing some challenges with this. Just to be reminded, this is not rated per the AMA guides. This is rated per GAF. And the GAF score is the Global Assessment of Functioning, which the doctor has to score out. And then you look at the California Permanent Disability Rating Schedule to see what kind of whole person impairment is associated with that GAF scoring. My best word of advice to you on this is to look within the schedule itself and look at the ranges of the GAF scoring and the description of what those ranges look like to see if they are consistent with your case. If they're not, then you need to go on a better, a more fact finding, kind of try and help it make sense to you. If it doesn't make sense, you need to challenge it. Some just things to touch on real quickly: neurological impairment, central and peripheral nervous system. That's chapter 13. So your tinnitus, your maybe some visual, like strange things going on. Maybe you have somebody who has some difficulties because of some brain issues happening. That would be rated per chapter 13. You treat it maybe similar to a traumatic brain injury type case. We haven't had any of those come across yet. Chapters 16 and 17, upper and lower extremities. I mentioned these because of the joint pain that we saw as potentially rateable. As a symptom that would be potentially rateable. Maybe their person has loss of motion or something like that as a result. And I mentioned it too, that brachial plexus that somehow came across our desk. That was like, whoa, okay, I guess that is a possibility. It seemed, yes, that would be reasonable if you were positioned for a prolonged period of time in a certain way that you could pinch a nerve and have long-term damage. So let's look at some examples. This is one of partial loss of smell, and that would be that anosmia that I indicated. 37-year-old sheriff, he had partial loss of smell, not really any objective testing you can do for that. The doctor puts some kind of scent packet under the patient's nose, and they have to subjectively report what they smell. The examinee in this case only has a partial loss of smell, so as a result, it has to be lower than that 3%. It's a 2% whole person impairment. That particular case cracked me up because, the claimant was telling the doctor, he couldn't even smell when his daughter had a poopy diaper. And I was like, really? Are you sure? Or are you just trying to get out of having to change the poopy diaper? In this particular case, this was a 46-year-old pizza delivery driver. He came in with a lot of symptoms: fatigue, frequent headaches, depression, and cough. There were no significant findings within the doctor's reporting relative to those complaints. Now, I had a gripe about it because I really think the doctor did a horrible job in their reporting. I'm not going to say that the person didn't have impairment, but I'm going to say, based on what the doctor reported, this is what the impairment needed to, this is what we needed to determine impairment. So in this particular case, the doctor didn't give us a lot objectively, but decided to give us a lot as far as impairment. Gave it 1% for headache, 2% for fatigue based on chapter 13, table 13-4, sleep and arousal disorder. And for the cough, he gave it 10% whole person impairment for asthma. Depression was not indicated or discussed by the doctor. That may have been rated separately, and we were not privy to that. We corrected this rating because the doctor, noted a normal lung exam, but did not give any pulmonary function testing results. Noted a normal Epworth Sleepiness Scale, okay, and there was no formal sleep study, but if there was a normal Epworth Sleepiness Scale, then that told us enough, and you probably don't need to authorize a very expensive sleep study, and gave, in this particular situation, we gave 1% for the headache, because that's all the evidence showed us we could give. Now, maybe they need to go back and write the doctor and say, hey, can we actually have the pulmonary function test results? Can we take a look at those and see you assigned impairment for the asthma table, but you didn't do the scoring? How are you getting to a 10%? And they need to really do a better job of documenting in some of these cases. And again, the depression was not evaluated. Now, this one was a challenge, and I don't think the doctor did a horrible job. I just think the doctor was inexperienced. This was a nurse, awesome, amazing lady, working the front line, 64 years old, still lifting up patients and doing transfers. I was impressed. Her resultant symptoms post SARS-CoV-2 was she had fatigue. In fact, so much so the doctor reported, I remember reading that report saying that even when she walked down the hall to the exam room, he could tell she was out of breath. So in this particular situation, she had objective findings that resulted in that METs of 7. There were no ECG changes on stress tests, and the doctor gave her a 29% based on coronary heart disease. The problem was there's normal ECG. She probably should have been rated. No, she probably shouldn't have. The most rateable component was this this pulmonary testing that was done, resulting in the 7 METs. She didn't have any findings that were objective or demonstrating heart disease, so you couldn't rate her for coronary heart disease. It was more appropriate to rate her per table 5-12, and we gave her a 2% impairment with a mid-range assignment of 18% whole person based on the 7 METs. Now, it's important to lay this out for you in real world terms, because this mistake the doctor made, that 29% using the coronary heart disease methodology, resulted in a 57% whole person impairment, which equated to about $94,000. Let's round it up to $95,000. The appropriate rating using the respiratory disorder methodology resulted in a 36%, which equates to $50,000. So you see this changed things up, depending not just the decrease in the assignment of impairment, but also the modifier. So you know that certain conditions change those modifiers. They can significantly change them. So be really aware that doctors aren't trying to overlap and that they really truly have placed them within the correct category and chapter to where the condition should be rated, and the evidence is there to support it. Now, I'm going to be wrapping up. We have 5 minutes. I wanted to leave a little bit of questions, but I have a couple of fun things for you if you're into it. One of my favorite articles doing this research, begrudgingly doing this research, was pericarditis after SARS-CoV-2 infection, another pebble in the mosaic of long COVID. I thought that was so right on, because it was like, as I was researching this, as I continue to see cases come in, as I continue to research it further, there are more pebbles being added to it. And, I mentioned earlier, in claims, we'd like to have everything in this nice package, right? We know what to do when it's a back case for the most part. When it's any kind of orthopedic case, we know. When it's a nerve case, it'll get a little bit more trickier. When it becomes an internal case, that's where it really becomes challenging. So be patient with yourself, be flexible, knowing the medical community is still trying to get a handle on this. But more importantly, do scrutinize the evidence as you get it in, because you do want to make sure that you pay what you owe, nothing more, nothing less, and make sure that it's something that, is supported by the evidence. My favorite podcast, I like to bring this up because this actually helped me through. Podcasts got me through 2 years of not seeing a lot of people, which I'm an unapologetic extrovert, so I was hug deprived. So I listened to a lot of podcasts, went on a lot of long walks on the beach. That's why I had that mermaid in that mosaic, because I am a mermaid when I'm not an expert on the AMA guides, or a mom, or a wife. So this podcast, Will Kill You, is one of my favorite podcasts. It's about diseases. I know it sounds like so nerdy and weird, but they're 2 disease ecologists, epidemiologists. They're both doctors, but they're just relevant and fun. They make quarantinis at the top of each episode. This podcast was actually created in 2017. 2017, long before SARS-CoV-2 was even a thought, right? So it was fun to go back and listen. I think episode 1's on the Spanish flu, and I was listening to it, and I'm like, oh my God, this kind of sounds like what we're going through right now in our world. There was so many similarities, but this podcast actually helped me kind of understand some of that stuff that I was telling you about our immune system and what our cells do, and just kind of the more deeper stuff, but in a real layperson perspective. And they're super funny. They're pretty quippy. They're both named Aaron. Super fun. So if you're looking for a good podcast, I think you might enjoy that. And White Knuckling Through Life, which Diane and I are the hosts of. So I'm going to leave it open for questions. Let Diane pop back on if she's ready and willing. I don't know if there's any questions.
I have a question. It says,
yes,
can or has anyone declared MMI that had worked, but that was related to work-related COVID?
Yeah. The question is, have we seen any cases where the person was determined to be MMI for work-related COVID?
Yes.
Yes, yeah. Those cases I gave you, those individuals were actually MMI. Those were all known exposures. Peace officers, that's presumptive. The pizza delivery driver, they had exposure, contact exposure at work, and the nurse, well, there you go. Those.
Okay, sorry about that. Can you go back to the page where you are sharing the COVID-19 website, because they would like to write that information down?
I'm going to put it in the chat screen too. I thought about that. I was like, I'm on a roll and I don't want to stop and copy and paste this right now, but right now is a perfect time. So to all of you, I'm going to put this link in the chat screen, and you should be able to click on it. And I just sent it to the entire audience. It's kind of cool, right? I don't know. I ran it by Diane this morning. I'm like, oh my God, look what I found. And then I realized I sounded really nerdy.
That's what we love about you, Leslie. You're so real.
I'm like an old lady in a 50-year-old body. Okay, this is a cool website. Yeah, the one that got me was reproductive system. But like, I do want to, can I also give you something that I really hope you take home? this is a very, 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 very small percentage of cases of people who actually had COVID. So the sky is not falling. I know it did seem like it was, but most of the research out there shows that it's a very small percentage. So don't freak out, and don't, you know, I don't know. I'm the kind of person that if I have a symptom, I go and Google it, and then I think I'm dying. But don't do that. Just I want to encourage you that this should be a smaller percentage of the cases that actually are COVID. Most of your COVID cases should get better, and you close them out, no permanent disability. But those ones that do, they're going to be a thorn in your side. They're going to be those challenging ones. But you know, just take it. And I do apologize, because I will say, if you are like with Beta Health, because I see some people on here, or Kaiser, or UC, you're going to see more than the people that are working, you know, the other types of cases out there, the small mom and pop shops. So you will see more, but that's just the demographic you're working with. Any other questions?
All right. We want to thank you all for joining us today, and want to say that we are in the middle of our 12 CEUs of Christmas. We do have another webinar this afternoon at 1:30. It's going to be also on COVID. It's going to be the neurological issues with COVID, and we will have a really great panel for that. So I certainly hope that if you haven't registered for that yet, that you go to macropro.com and that you register. We have other great classes. I think this is our 5th webinar, so we still have 7 more classes, so please join us. We hope that you have a fabulous day, and remember, when you need records, to call on MacroPro. Have a great day now. Bye-bye.
Bye.